What is heart disease and how does it affect Americans?
Of course, you're taking heart disease as an extraordinarily broad subject. When you say heart disease, you're talking about heart and the vascular system. And of course, the heart and the vascular system is what controls the body. So there are many diseases that can affect the heart and vascular system. And it turns out, of course, that the heart and vascular system is by far the leading cause of death in this country. Because if you use vascular system, you have to add in stroke, you have to add in heart attack, there are many peripheral vascular disease, so heart disease is clearly the number one most important killer of Americans. And of course, we say that word killing, but the fact is, of course, all of us are going to die. But when all of us die, and you divide all the causes of death, still heart disease is number one by far.
What age groups are at risk for heart disease?
Well, the answer is, of course, there are heart diseases that affect every age group. The individuals, the babies that are born with a congenital heart disease, heart valve abnormalities, is a very small number. But yet for the parent that's having a child who's a blue baby or has atrial septal defect or ventricular defect or transposition of the great vessels, or there are many congenital heart disease, that's a very important group. Teenagers, athletes that have sudden death due to idiopathic hypertrophic subaortic stenosis, that's a small group, but certainly very important to the high school team or the individual or the family that loses such a child. And we all have known about individuals who have dropped dead by playing sports. You add up, go up the level a little bit, and usually coronary artery disease, or heart attack disease, heart attack causing disease, that usually comes into play in the 40s. Obviously there's some in the 30s, but it comes to play in the 40s and 50s and 60s. And if you get older, that's when usually stroke comes into play. So the answer is all age groups are affected with heart disease.
That brings up my second question. What is stroke and how does it affect Americans?
Well, stroke, of course, is again, I'm not trying to make everything too complicated. Stroke is a broader disease. When you say stroke, that can mean several different things. The most common kind of stroke is a stroke that occurs when some of the blood supply to the brain is blocked off with a thrombus, with a clot, blood clot. So that's one kind of stroke. Another kind of stroke is called embolic stroke. And that's the stroke when something else breaks off from the heart. For example, a vegetation from a heart infection, that can break off and go to the brain. That's an embolic stroke. Or you can make a little clot in your carotid artery, and that breaks off and goes to the brain. That's embolic stroke. The other kind of stroke, the most common form, is hemorrhagic stroke. That means that a blood vessel in the brain burst, and that destroys the brain. But the mechanism is really all the same. It means that if you clot a blood vessel, or you burst a blood vessel, or you block off a blood vessel with an embolus, embolic stroke, you're blocking off blood supply to the brain. And that part of the brain can die. And depending on the part of the brain that is dead, depends on how the stroke manifests itself. We've all known, probably most of us have had grandparents or friends or great aunts or great uncles that have had a stroke. And some of them can't speak. Some of them are paralyzed on one side or another. Some of them are just mildly have their face drawn up. So it depends on the effects of the stroke. Depends on where in the brain the blood supply is interrupted. And any of these mechanisms can interrupt the brain. The other kind of stroke that I didn't mention, of course, was the subarachnoid hemorrhage kind of stroke. That's when in the base of the brain, the blood vessels that are there called the circle of Willis, one of them can create a berry aneurysm or an outgrowth on one of the vessels. That can burst and cause a type of stroke.
So do you see stroke happening in more age groups than another?
Well, obviously, the most common age group are the elderly. Elderly is generally described as 65 or older. It means I'm very, very elderly. But again, there are strokes that occur earlier on. My nephew, at age probably about 28, was jogging through Central Park in New York, and he had a subarachnoid hemorrhage. He had a cerebral aneurysm rupture. He was rushed to the hospital, ultimately had surgery. Now he's fine. But the answer is, you can have stroke at a young age. or you can have but the most common kind is older. And I totally neglected the kind of stroke that's very interesting. It happens in the young, which is sickle cell anemia. Those individuals can get intravascular clotting, and you can have young kids end up with stroke. I've seen several of those over the course of my time in practice. So that means that you can have it young, you can have it middle age, you can have it old. By far, the most common is old.
Are males or females at the highest risk for heart disease and strokes?
Well, the most common, it can be both, of course.
Okay.
But in terms of most common, male predominates.
Really?
Yeah, but I'm not sure that's that big a differentiation in terms of stroke. But the male is a little bit more prominent.
Why is that, do you think?
I'm not sure. Certainly, the male, in terms of heart attack, a different kind of heart disease, coronary artery disease, is much more prominent in males. I think the differentiation kind of probably evens up pretty well male and females as you get older, but I really don't have a specific, we could research that right quick, but I don't have it in my mind.
What race is at the highest risk for heart disease and stroke?
Well, it again depends. You said heart disease and stroke.
Yes, just because.
In terms of percentage of race, probably stroke is probably black. And the reason for that is because hypertension is more prevalent in black, and hypertension is a very definite precursor of stroke. But I think that if you take away hypertension, I would suspect that it's pretty well equal racing, but equal by race. But if you leave hypertension in the mix, the black would be the more common race to have stroke.
Okay.
I'm not sure of any other information that would differentiate other races in terms of this, Asiatic, etc. I really don't know.
What causes heart disease and stroke?
Well, again, we depends on what kind of heart disease and stroke we're talking about. Heart disease, of course, the kind that I mentioned earlier, is coronary artery disease. That's generally felt to be a combination of a lot of things. Genetics, certainly the whole cholesterol story is a part of that, not the whole story. Hypertension becomes a part of that. Smoking becomes a very important part of coronary artery disease, not exclusively part, but all of these factors play into the causation of heart disease and stroke. Atherosclerotic stroke that's the baseline of the thrombotic stroke that we talked about, and all of these factors enter into that. The smoking, the cholesterol, and of course the things that affect general things. In a more general thing is, of course, cholesterol is affected by diet. Exercise is a component of this, and it's shown that regular exercise can be a protective factor for coronary artery disease. So your question doesn't have a simple answer.
Yeah.
But I think that those factors come to play when you're talking about that.
Yeah. What screening or diagnostic tests are available for heart disease and stroke?
Well, we're talking about, of course, early on, for example, we're looking at sickle cell disease as a cause of stroke, which it can be, discovering you have sickle cell disease. If you're talking about valvular heart disease, which can come from rheumatic disease or it can be congenital, obviously the stethoscope, listening to the chest, is a means of screening for that. If you talk about coronary artery disease, if one is becoming symptomatic with chest pain, then there are a number of tests that you can do to find that. You can do a stress test, with exercise stress test. You can do a nuclear stress test. The ultimate test, of course, is a coronary arteriogram, in which you insert catheters to the heart, squirt in dye, and see if there are blockages in the heart. Preventative, to find out about other causes of that, you put a blood pressure cuff on and see what your blood pressure is. If you're worried about your carotid artery blocking off or becoming stenotic as a cause of stroke, you listen to the carotids. And of course you can further evaluate that by using an ultrasound device that can be placed over the carotid, and that can determine what level of stenosis or what level of blockage you have in that artery. So again, the answer is that there are many ways to go at finding out, diagnosing stroke, depending on what you're looking for. It's interesting to me that if you look at the history of all of this, my cardiology training was in 1966 to 1967. That's a long time ago. At that time, coronary artery disease was diagnosed by after you already had the heart attack, and after you and you could find it by electrocardiogram, and there were some simple blood tests that would suggest it but not prove it. After that came along, a much more definitive blood test. The whole issue of coronary arteriography, that didn't really come into play until 69, 70, 75. Now it's, of course, widespread.
Yeah.
So there, and the carotid ultrasound. It's interesting that to determine a carotid artery blockage. It's interesting that Dr. James Toole at Baptist Hospital in Winston-Salem was one of the pioneers in establishing carotid ultrasound as a means of finding carotid artery disease, and then letting that be a precursor or a indicator that that person is probably stroke born. So right here in North Carolina, that's a very important part of that history.
Wow.
Because he did that in Winston-Salem. He came from the University of Pennsylvania, which was my alumni. So I'm alumni of the University of Pennsylvania, and so I'm very happy to follow Jim Toole when he moved from Penn to Winston-Salem, and that's where he did his pioneering work.
That leads to my next question. When should someone get screening and diagnostic tests?
Well, I think that's also an interesting question, because every time you go to the doctor, and in a sense you are being screened broadly, because the likelihood is you're getting a blood pressure.
Yeah.
And that is a specific screening course.
Yeah.
If we move through life, there are, of course, much more elaborate screenings that can be done. For example, if you're a male in your 40s that have a strong family history, and you're a smoker, you're at great risk for coronary artery disease.
Yeah.
Generally, many people would wait until that individual starts getting indications of heart disease in terms of maybe some chest pain, more easy fatigability, can't work as hard, and then start doing the other testing procedures. Exercise stress testing on a treadmill. Perhaps there's a test out there called calcium score screening, which is a CT scan of the heart, looking at calcium. There you can count calcium deposition in the arteries, and a person with a high score is more at risk, and that person may be led on to coronary arteriogram. That's controversial, because you can diagnose a lot of people with high calcium stores that really are not that much risk for heart disease. It's more important, it seems to me, to take that individual who is having risk factor behaviors. He's smoking, he's not exercise, he's obese, he has a terrible diet, his cholesterol his LDL cholesterol is 113 or over 130 or maybe 170 or 200. That individual, that's when you start working with that individual in terms of reducing the risk factors that are involved. And sometimes that becomes more important than screening. I do not find that that some of the doing screening routinely generally is not very productive unless you've got something that indicates the need for that screening or the need for early symptoms of that disease. Because if you screen for that disease, your chances are you're going to pick up a lot of false positives. When you pick up a false positive on a screening test, that inevitably leads to a whole cascade of additional studies and tests that have some hazard. The test itself have hazards, and certainly the cost is out there. And in my opinion, that's one of the reasons why our healthcare system is crashing. Because we're using too much testing. We're using too much screening.
Spending too much
we're spending too much money to no avail. It'd be much better to spend that money to try to keep teens from starting to smoke, for example. And that would prevent a whole lot more heart disease and screening healthy 50-year-olds without symptoms for their heart disease. Then you find some positives, then you follow up with those positives, and all at once you spend a bunch of money, and usually with nothing much coming from it. That is not to say that some routine screenings don't pick up things occasionally.
Yeah.
I'm thinking of the ads that we see in the newspaper. Come to Rehoboth Baptist Church. Our parking lot this Saturday is going to have the big truck here, and we're going to screen your carotids for aortic aneurysms. We're going to do electrocardiogram. That rarely picks up an individual with disease that wouldn't have found it in a much more cost-effective fashion in another way. By having symptoms, going to the doctor, and then he initiates a screening. So that's why I basically am against mass screening. That may
That's
be
a good
controversial to
point.
your professors, but I would back that up with statistics if they wish me to.